Good morning, all. So, first of all, I would like to thank Samir for calling me again to Nagpur. It's a wonderful city. So, what we're going to do in another 20 minutes' time to see an overview of airway foreign body removals. Okay. So, greetings from Vishakhapatnam. It's a coast city in India. So, this will be my agenda for today. So, we'll start with introduction. What are the instruments what we use for flexible and rigid bronchoscopes? So, we'll start with simple airway foreign bodies. And we'll go with tracheal foreign bodies, bronchial foreign bodies. So what if the foreign body is presenting with a pneumothorax or a mediastinal emphysema? And distal airway foreign bodies which are not visible with a bronchoscope. And foreign bodies where you have a sharp foreign body where it has caused mucosal perforation, the perforation inside the airway, and bilateral airway foreign bodies. So we all know foreign body airway aspiration is a potentially life-threatening event. Why? Because it blocks the airway. So thereby causing impairment of oxygenation and ventilation. So it is a medical emergency. So most commonly we see in children, but also adults can present with foreign body aspiration. So in children, the most important point is careful clinical assessment because unwitnessed foreign bodies are very, very, very common. So what you will require to use radiology and clinical judgment. So coming to the clinical features. So most commonly you will have non-specific findings like generalized wheeze, cough, and the classical triad of wheeze, cough and diminished breath zones are not commonly present, but doesn't mean that you should not diagnose the case. And I feel this is the most important point. It's called regional variation of aeration. So what does it mean? So if you demonstrate absence of breath sounds or diminished breath sounds in one part of the lung, and that is a very, very important sign to diagnose foreign body aspiration. So coming to the instruments, we have two instruments, flexible and rigid. So if you ask me what are the best bronchoscope what we can have to do a foreign body retrieval, it would be probably this two bronchoscope, either a 4 mm, 2 mm or a 2.8, 1.2. As I've told you, mostly we see foreign body aspiration in children rather than in adults. So your therapeutic bronchoscope is probably of no use in children. So coming to the accessories, so these three accessories should be there whenever you are attempting a foreign body aspiration. The first is a basket, second is a forceps, and third is a balloon. So that's the order of priority. The first instrument what we use in a foreign body aspiration is a basket. So we'll come to it one by one. And you can also use a cryoprobe in especially if the foreign body has a water content in it. Some other instruments like triprongs, grasp fit forceps can be used, but that doesn't mean that only with that we have to do it. So coming to the basket, we have two types of basket. One is a 4-wire distal opening basket and another is a 4-wire proximal opening basket. Basically what we need to do is to pass the basket distal to the foreign body, open the basket and try to engage the foreign body inside the basket. So once you engage it, you can retrieve it. So whereas in a proximal opening basket, you have to open the basket proximally before the foreign body, push it gently distal so that you can engage the foreign body. So that's the difference between a proximal opening and a distal opening basket. So coming to the forceps, so the most important point what we need to remember in forceps selection is the size of the forceps. So you have different sizes, 1.8, 1.1. So according to the bronchoscopy channel diameter, you need to select your forceps. The ideal forceps what we choose is a rat tooth forceps. So ideally this is the forceps what we choose. So whenever you are engaging a foreign body with a forceps, remember most of the times it is one sharp edge will be there. So make sure that you hold the forceps in such a way that the fulcrum is as proximal as possible. Otherwise, if you hold it just distally, the high chances that it will slip, the foreign body will be slipped. So in the optical forceps, we have peanut forceps so that you can visualize the foreign body and with the same instrument you can remove it. So coming to the balloon, so again, so whenever you want to use a balloon, so you pass it distally, inflate the balloon and proximally bring the foreign body so that you can engage it either with a basket or a forceps and extract it. So where does balloon stands in extraction of foreign body? It stands at disimpaction. So what is disimpaction? You have foreign body somewhere distally. You want to get the foreign body proximally so that you can engage with the forceps or a basket. So that's the reason balloon is used. And sometimes occasionally you will have this pearl bead where you can pass the the balloon directly inside the hole of the pearl bead and extract the foreign body. So these are rare conditions, but most of the times what we use is to distally disimpact the foreign body to get it proximally so that you can extract it. So where does cryo stands? Any foreign body which has water content, let it be some seeds, mucus plugs, blood clots. It's a wonderful tool. So it serves as both disimpaction and also extraction. Because why? So once the foreign body is identified, you take the cryoprobe and freeze it over the foreign body. So it will get stuck to the cryoprobe. It will be used as a disimpaction tool, and also the same tool can be extracted it out. So coming to the rigid system. So these are Chevalier Jackson's rigid bronchoscope, the older systems, where you have to see through the hole to see inside the airway. So there is no telescopic view, it is a naked eye examination. It is not so easy. Just imagine if you have to see through the small hole, imagine you have to pass a forceps through it to extract it. It's not so easy at all. So right now we have an endoscopic image and you have an optical forceps where you can combine the vision and the hand instrument in single unit. You can extract the foreign body. That's the greatest advantage. So this is a current generation ventilating pediatric rigid bronchoscope where there are different parts to it. So we can use this so that safely we can extract it. So, and this is the most important tool when you are using a rigid bronchoscope. This is called an optical forceps. As I told you, you combine the telescope, that's a vision, and the hand instrument, that's the forceps, to combine to become an optical forceps. So whether you have a vision and also at the same time you can extract it with the forceps. So that's the greatest advantage. So what are simple foreign bodies? So these are more proximal foreign bodies where it doesn't require much of the instruments to judge which instrument has to be used. If it is proximally there, you can just pass any instrument, whether it can be a basket or a forceps, and extract it. It doesn't take much time, whether it can be a rigid system or it can be a flexible system. It doesn't really matter, you can extract it. But some foreign bodies are very difficult. So in this case, this is a subglottic foreign body where you can see basically a patient had hypoxia. So imagine if this is the airway, that's the trachea, and that's the foreign body inside. Imagine the level of ventilation what we can see. So whenever you see this and you can push the foreign body at the carina, because that's the widest part, so you can hold with any of your optical forces and extract it. I'm not telling for each and every case. Only in this case where it is a subglottic foreign body near occupying the whole trachea, where the ventilation is difficulty, the priority is not removal, the priority is ventilation. If you don't ventilate the child, most of the times you will not achieve your targets. So another case, right the main bronchus foreign body, that's a tamarind seed. Initially tried extraction with an optical forceps. So after extraction I am not able to retrieve it through the subglottis. So once the foreign body is inside, you can see the amount of bleeding inside the trachea. That's the trachea. So that's the amount of bleeding inside the trachea. So it's all granulation. That's what it's bleeding. So these are challenging cases. They cause more hypoxia. So after repeated attempts, we could not do anything. So what we did a tracheostomy and extracted the foreign body through the tracheostomy site. So when you have a tight subglottis where you can't extract it, the one of the method to you do is a tracheostomy and extract it through the tracheostomy site. So another case, same. The child came with an whistling sound. There was a whistle got stuck at the subglottis. So baby deteriorated fast. So initially tried with an optical forceps. Again, the subglottic foreign body, optical forceps. So we tried multiple times, but unfortunately what happened was one of the jaw of the optical forceps got broken and dislodged inside the airway. So now there is an iatrogenic foreign body inside the airway because of the broken jaw. So luckily I had another spare optical forceps. Initially what we extracted the broken jaw, what I have done. So what are the options now? Again the same problem, tight subglottis, not able to retrieve. What are the options? Balloon, basket's not going to work. The best instrument where you can exert more force is an optical forceps. More than that, there is no other instrument available. So if your optical forceps has failed, to retrieve the foreign body to the subglottis, most of the times these two will fail. There is no doubt. So that problem is subglottic edema. So that can be because of multiple attempts of removal of foreign body and also multiple passages of rigid bronchoscope. So that can cause some edema and cause stenosis at the subglottis. So what next? Yes, we can do a tracheostomy. What I've shown you the first case. Do a tracheostomy, extract the foreign body through tracheostomy site. And another one, what we can do is to serially dilate the subglottis with increasing diameter of bronchoscope. So once you dilate the subglottis to an ideal diameter, you can extract the foreign body. Then that's what we have done. So we serially dilated the subglottis with increasing size of the bronchoscope diameter, and we could able to extract the foreign body. This is a technique what I am showing you. Another case, if you have a tightly impacted foreign body in the proximal bronchus, very tightly impacted, left lung collapse, tightly impacted foreign body, basket, balloon, cryo, everything failed. The only instrument I have told you, the best instrument which you can extract maximum force is an optical forceps. So in these cases, what you can do a piecemeal extraction. So that's what we have done in this case, piecemeal extraction of foreign body, and we could able to retrieve the foreign body. This is what is called as karakai in our language. We call it as a gallnut because this gentleman keeps the nut inside the mouth and sleeps overnight when you have a chronic cough. This is very common in my place. I don't know in Maharashtra what is it. This is a very, very common, whether it can be a supari or it can be a gallnut. It's very, very common. We get so many foreign bodies in adults especially. And this is a misnomer that you keep it in the night and the cough disappears, but the nut disappears. It goes inside the airway. And the 8 minutes. Okay. So what if you have foreign body with a proximal granulation? So what we are seeing is, now you know there is a foreign body inside the airway, but something proximally it is obstructing. So when you have something proximally inside the airway, that is foreign body, you're not able to see. Ideally, what you need to do is to address the proximal issue. So here the proximal issue is this granulation tissue. So once you remove the granulation tissue, you can able to see the foreign body and you can extract it. So here what I've used is a hot snare. So extract the granulation tissue first. So used a hot snare. So once you extract the granulation tissue, then you can visualize the foreign body inside the distal airway. So once you visualize the foreign body, again, criteria. So distal airway foreign body, the first tool what we use, this is what I am doing in flexible. The first tool what we use in a basket. So if the basket you use, again, if the basket fails, use a balloon. The balloon fails, cryo. And that's the series I follow in my routine. So that's the foreign body. It's basically a cloud which has got stuck there. Tried with a balloon, failed, but used a basket and got extracted out. Another case, foreign body presenting with obstructive hyperinflation and pneumothorax. So what is the pathogenesis? Why does the obstructive hyperinflation and pneumothorax cause? It's basically because of ball wall mechanism. So once you have one bronchus which is obliterated with a foreign body, the air will go inside the lung, but it doesn't come out. It's basically a ball wall mechanism where you can cause hyperinflation of one lung. So once it crosses a threshold, either it can rupture through to the mediastinal part or to the lateral part. Anywhere it can rupture, the lung can rupture. So that causes what we see here, mediastinal emphysema, pneumothorax. In this case, so this is what, I'm sorry you're not able to see it. So what you can predominantly see a mediastinal emphysema. So there is no pneumothorax in this case. In this case, there is no pneumothorax. So what can we do? So if you call the anesthetist and you show them this X-ray, most of the times they will deny the case because there is high chances of barotrauma in these cases. So you have to be talking to the anesthetist properly and ask them this could be managed well and extract the foreign body. So you don't have to place a chest tube in this case. So this is the corn seed which has gone to the right lung and extracted with an optical forceps. So another case, 2-year-old child, again sudden onset of breathlessness, foreign body with, now you can see a pneumothorax there. So whenever you see a pneumothorax, please don't proceed. So directly put a chest tube first. So you will get better lung expansion and your anesthesia colleagues will not complain to you. So in previous case where there was a mediastinal emphysema, you can't do anything much. So we placed an ICD first and extracted the foreign body. Again, this is a Bengal gram. So this is not my case, this is a Hari's case. So this is a distally lodged pin. So where bronchoscopically you can't see that pin. So the technique in this case, what we need to follow is to use a C-arm, and it is not so easy. So first you have to read the CT scan properly, identify the culprit bronchus. Once you identify the culprit bronchus, looking at the C-arm, you have to go inside and try to hold the foreign body with your regular forceps, and it is not an easy job. You can't see anything in the airway. What you can only see is the two-dimensional image in a C-arm, and it is not so easy. It is challenging case. So another case, so what if you have distal impacted foreign body, everything has failed, the basket failed, balloon failed, your forceps, forceps has failed. So again, I told you, once all these things fail, I choose to use a cryoprobe again for disimpaction and also for extraction. Here, it was a small child, distally impacted. I'm not able to extract with a basket or a balloon. So in this case, I used a cryoprobe, 1 mm cryoprobe, to get the foreign body proximally. So once you get it proximally, the next job will be very easy to extract it. It doesn't take much time. So that's the 1 mm cryoprobe. I am just gently getting proximally so that I can extract it out. So what if you have a sharp airway foreign body? Ideally, what you need to do is to hold the foreign body and get it inside your conduit. The conduit can be a rigid bronchoscope or an endotracheal tube. So this point has to be kept in mind. The sharp end of the foreign body should be inside the conduit. It can be a rigid bronchoscope or an endobronchial tube, so that you will minimize the chance of mucosal perforation. So once you hold it inside an endotracheal tube or a rigid bronchoscope, the chance of perforation just literally disappears. Another case, so I'm just going to skip this case. Yeah, so this is a bilateral airway foreign body. What you can see, the endotracheal tube, right side upper lobe consolidation. So the tube is slightly towards the right main bronchus. You can see a foreign body there. That's the foreign body, and one more foreign body in the left main bronchus. So this is the bilateral airway foreign body. Baby is arrested inside the ear. Arrested, CPR done, intubated, took for CT scan, immediately we rushed. So that's the, I'm sorry you're not able to see, that's one foreign body in the right intermediate bronchus and another one in the left main bronchus. The only one bronchus which is left out is the right upper lobe, and that too has a consolidation. Just imagine the ventilation part. So that's the bronchoscopic, initial bronchoscopic, that's the intermediate bronchus where you can see, and that's the foreign body again in the left main bronchus. So what you need to do in this case is to quickly get the ventilation part properly. So what we did, we initially thought we'll remove the right side part. Inadvertently, I pushed the foreign body inside. But it was good for me, at least I was able to maintain the ventilation. The oxygenation has come up and PCO2 has come down. So that's the reason what we did was extracted the right main bronchus foreign body. It went to the right lower lobe. We were able to extract it. Yeah, I'll be fast. So the left one, we used a balloon to extract it. So this is the case which you can show there's nothing is superior, whether it is a rigid or a flexible, both can be used in the same case. So this is one child, this is my last case. So you can see a mother holding the child, basically coming 60 kilometers away from where I stay, gasping for breath, history of aspiration and everything. 10 minutes before arrival, baby was unconscious, not responding to commands. When the pediatric team is on in the ER, the baby was unconscious, pupils dilated, but they did CPR. They were able to get the saturation up, intubated immediately, and we revealed the patient directly to the OT. I was waiting in the OT because I got to know half an hour before that the patient is coming. We wheeled it immediately. Then once we are able to extract the foreign body out, this is basically a groundnut which is there inside. Once we were able to extract the foreign body, we were able to get the ventilation back. But the challenging part was baby was unconscious, pupils dilated, so we don't know what has happened to the brain. So we are just praying to God, let us see whether baby will recover or not. Then the funny part was the case sheet was not put. There was no documentation done. So everybody was in a rush. There was absolutely no signs were taken for consent. So then after the procedure, the sister is getting, sir, this is the case sheet. And nobody has thought of putting a case sheet down, writing it down, get the consent, procedure over. So we did everything. And by evening, by after 3 hours, baby woke up. So that was very, 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 very useful for us, because we are just praying that the baby should wake up. And this is what I observed in children. This is not so common in adults. Even though you have almost near arrest, most of the times children do better than adults. So this is what I say to my last point. I'm just finished. So airway foreign body is the most satisfying procedure for an interventional pulmonologist. Why? Child in respiratory distress, and it is a curative procedure. There is nothing called diagnostic procedure. So you see, you remove, and you do the job. And majority of times you will able to extract, more than 90-95% you will extract it, and it can be discharged as early as possible. So that's why I say airway foreign body extraction is the most satisfying procedure for an interventional pulmonologist. I'll just go to summarize. I feel each and every foreign body aspiration is unique, and you should follow safe removal protocol. Rigid bronchoscopy is a time-tested system. Physician should be well versed with this rigid bronchoscope. For impending respiratory failure, rigid is superior over flexible. And the same time, rigid can be used as a conduit. You just have to use the same rigid bronchoscope, pass a flexible instrument. You don't have to remove and put an ET tube to pass your flexible bronchoscope. And for rigid airway foreign body, the sharp airway foreign bodies, rigid is the best system. And distal airway foreign body, flexible is superior over rigid. I feel there is no single best instrument for all foreign body cases. Rigid or flexible, none is superior over other. Either one can fail. Both are complementary to each other. Thanks for your patient listening.